Today we'll be covering Chapter 29, Clinical Virology. This is a large chapter, so it's divided into two parts. So this part is covering Section 1. Clinical virology is a challenging and exciting area of clinical microbiology. It's changed quite a bit over the years, from testing being performed in highly specialized diagnostic labs, and only a few, to now being able to be performed in routine laboratories. So there's been significant advances in diagnostic methods that have transformed the field. So there's newer methods with faster turnaround times. Test results are now more clinically useful. And then, of course, the development of molecular diagnostic testing that results in earlier intervention, early treatment, and better outcomes for the patients. So the first thing we'll discuss is the structural characteristics of viruses. So you may remember some of this from our immunology lecture series, and actually this diagram was taken from those PowerPoints. So viruses are submicroscopic particles that are measured in nanometers, and their basic structure consists of core of DNA or RNA packaged in a protein coat known as the capsid, and then an outer envelope may be present in some viruses that consists of glycolipids and proteins derived from the host cell membrane. So the genome plus the capsid is called the nucleocapsid, and the entire virus particle is referred to as the virion. Virions can exist in three morphologic types, one being helical, another icosahedral, which is a geometric shape with 20 triangular sides, and the third being a complex type. Of note, when an envelope is present, that masks the shape of the virion, so those ones can appear pleomorphic or variable shaped. In addition to the different types, the viruses also vary in size. So there's extremities in size. For example, the pox virus is the largest, and that one measures at 260 by 450 nanometers, whereas the poliovirus is the smallest, measuring only at 25 nanometers in diameter. This slide has diagrams of the different morphologic types of virions. On the left, figures A shows a helical virus. So a helical virus has a capsid shaped in a filamentous or rod-shaped structure that has a central cavity that encloses its nucleic acid. Figure B in the middle shows an icosahedral capsid. So that's a three-dimensional 20-sided structure with 12 vertices. These capsids somewhat resemble a soccer ball. Both helical and polyhedral viruses can also have envelopes. And then the last diagrams show a complex virus. So viral shapes seen in certain types of bacteriophages, such as a T4 phage and pox viruses, like vaccinia virus, may have features of both polyhedral and helical viruses, so they're described as complex viral shapes. So originally, viruses were classified by the diseases they caused and their host range, but now there's more structural classification. So they're classified in order of the orders, then families based on the genome type, the genre, species, the number of strands in the genome, so whether it's double-stranded or single-stranded DNA or RNA, the morphology, the presence or absence of an envelope, and then the nucleotide sequence. So Table 29.1 in the textbook provides a good summary of viruses that cause human disease based on their nucleic acid characteristics and taxonomy. The table breaks down whether the virus is double-stranded DNA, single-stranded DNA, double-stranded RNA, or single-stranded RNA. It also includes the family, genus, and species of the viruses that we'll discuss in this chapter. Viruses are obligate intracellular parasites. They must be inside a living cell and use the host cell's machinery to replicate. There's various steps involved in viral replication. In the first step, for infection of a cell to occur, virions must absorb or attach to the cell surface. Absorption is specific for certain cell receptors, and receptor distribution will determine the entry point into the host. Most host cell receptors are glycoproteins, some of which include the immunoglobulin superfamily molecules. As an example of one type of glycoprotein, the virus is attached to specific receptors on the surface of a susceptible cell by means of specialized structures called adhesion molecules. The next step in viral replication is penetration. Viruses can penetrate the cell by several different mechanisms, and penetration is virus dependent. Naked virions can penetrate the cell membrane directly. Enveloped viruses may enter the cell by fusion with the cell membrane. And a third method of penetration is endocytosis, where the enveloped virus enters the cell in a cytoplasmic vacuole. Once inside the cell, the virus loses its protein coat, releasing the genome. This goes into the next step of uncoding. This is the process where RNA viruses usually release the genome into the cytoplasm, where most DNA viruses release the genome into the host nucleus. The viral genome then directs the host cell to make viral proteins and replicate the viral genome. So the step after the encoding is the replication and translation. So this is where the viral genome directs the host cell to make viral proteins and replicate the genome. Metabolism of the host cell may be completely stopped at this step. The next step is the assembly of or maturation of the virus particles. The capsid protein subunits aggregate to form capsomeres. Then the capsomeres combine to form the capsid. The capsid and the genome associate to form the nucleocapsid. The new virions are then released by lysis if they are naked viruses, or budding if they are enveloped. During the budding part of the host cell, plasma membrane surrounds the viral capsid and becomes the viral envelope. And this is the last stage, the release or egress. So this diagram was taken from your immunology textbook again, showing the viral replication and the associated stages. So you'll see at number 1, this is the attachment of the virus. Then step 2 is where penetration occurs. Step 3 is uncoding. Step 4 is transcription to produce additional nucleic acid. Then step 5 is translation to produce viral proteins. At step 6, we have the assembly of the viral components. And then at step 7 is the budding off of the host cell membrane or host cell lysis results. And finally, step 8 is the release of viral progeny. The next topic to be discussed in this chapter is the laboratory diagnosis of viral infections. Laboratories provide different levels of service depending on the mission, financial resources, and need. Full-service virology labs provide viral identification by cell culture, but not all medical treatment facilities provide this service. Rapid tests are available to detect viral antigens, such as immunofluorescence or enzyme immunoassay, while other labs may use serology testing by detecting antibody rather than the viral antigens themselves. Examples of viral testing are cell cultures and rapid tests, such as viral antigen tests, as mentioned before. There has also been rapid test availability that have CLIA waivers, which allows physicians' offices and clinics to do this sort of testing. So the first thing to evaluate when doing testing for viruses in a laboratory setting are what are the appropriate samples and when are the viruses most likely to be present. So the best sample would be collected during early stages of infection, so as early as possible, which may be even before symptoms occur, because after 3 days of onset, the sensitivity of tests may decrease rapidly, since viral shedding is usually the greatest during the early stages. Possible specimens that can be collected include aspirated secretions, along with swabs, as these are sometimes easier to obtain. And just as of note, which has been mentioned before, calcium alginate swabs should not be used for viral testing because those could kill the viruses. When collecting samples for viral testing, they should be kept moist to avoid desiccation that can destroy the viruses. Usually, viral transport media should be used specifically for respiratory samples, swabs, or tissue samples. The viral transport media contains buffered isotonic solution with a protein such as albumin, gelatin, or serum to protect less stable viruses, and sometimes it also contains antibiotics to inhibit contamination with bacteria. Although many sources require the use of a viral transport media, some do not. So there's some specimens where it is not indicated, and these include blood, bone marrow, cerebrospinal fluid, amniotic fluid, urine, pericardial fluid, and pleural fluid. Once the specimens have been collected, the samples are best cultured immediately, but if testing cannot be done as soon as possible, they should be refrigerated at 4 degrees Celsius. Samples should be frozen only if testing cannot be performed greater than 4 days, and when frozen, they must be stored at -70 degrees Celsius. Samples should never be frozen below -20 because these temperatures facilitate crystal formation, and that can disrupt the host cells and result in loss of viral viability. Also, repeated freeze-thaw cycles is not recommended, since this also can result in loss of viability. The appropriate specimens for best recovery include respiratory samples, lesion aspirates or surface swabs from lesions, stool samples, urine, blood, tissue, biopsy, or cerebrospinal fluid. The samples to be collected for viral culture or detection are best if collected directly from the affected site. Table 29.2 summarizes what will be discussed on the next few slides regarding laboratory testing for common viral pathogens. The table lists the body system affected and respective antigen detection, viral isolation, serology, culture specimens, and molecular testing. There are 4 major methods for detection of viruses that will be discussed. The first being direct detection of viruses in clinical specimens. The second, nucleic acid-based detection, such as molecular testing. The third, isolation of the viruses in cell culture. And the fourth includes serologic assays to detect viral antibodies. Of the 4 different methods, in general, direct detection is not as sensitive as culture methods, but it can offer quick results to allow rapid therapy if indicated. Microscopy can be done using bright field, which is the best for detecting pox viruses, but it can't be used for other viruses that are too small to observe. Electron microscopy can be used to detect non-culturable viruses such as Norwalk virus in stool, but this type of microscopy is not used in the routine clinical microbiology lab. Microscopy can also be used to detect the effects of viruses on cells themselves. So although the viruses cannot be visualized, the cytopathic effect, or CPE, can be detected in cell scrapings from infected sites, and this can aid in identification of the infecting virus. DFAs, or direct fluorescent antibody, can also be used to label patient cells with antibody and detect viral antigen. The next method, enzyme immunoassays, are commercially available but are less sensitive than cell culture or immunofluorescence. And then nucleic acid testing, the molecular testing, can aid in detection of virus nucleic acid and also in quantitation of viral load in some methods. These figures are examples of immunochromatographic membrane assays. So on the left, figure A is showing a card format rapid test. It's known as the Binax Now, and this is for RSV and flu A and B viruses. So these rapid tests can detect 3 of the common respiratory viruses. On the right, figure B is showing examples of a positive and negative result. So you'll see the control line at the bottom indicates that the test was performed appropriately, and the sample line, if a line is present, indicates that it is a positive result. Isolating viruses is still considered the gold standard against all the other methods. So there's 3 methods of viral isolation that can be used: cell culture, which is the most common method, animal inoculation, and embryonated eggs. And we'll discuss these 3 methods in a little more detail in the next slides. So the first culture method is cell culture. So this is also known as tissue culture. So this method involves growing cells in a flask or test tube to detect viral infection. So there's 3 different types of cell culture. The primary cells are obtained from tissue removed from an animal for this type of culture. The tissue is then finely minced and treated with an enzyme to disperse the individual cells. Cells are then seeded on a surface to form a monolayer, and then only one cell division occurs. And viability for this test is maintained through periodic removing of cells from the surface, diluting them, and placing them into a new container. This process is known as splitting or passaging. Of note, primary cell lines can only be passed a few times before new cells need to be obtained. An example of this type of cell is the primary monkey kidney cells. The second type of cell line that can be used is the finite cell culture. So this can be divided, but is limited to 50 generations of passage. Finite cell cultures use diploid cell lines similarly to the primary cell culture lines. So diploid just means that they contain 2 copies of each chromosome. With the finite cell culture, greater than 75% of the chromosomes are normal in this type of cell line. An example of finite cell cultures is the human neonatal lung cells. And then the third type of cell culture involves heteroploid cell lines. So these are cell lines that have continuous established cell lines. So they have less than 75% normal chromosomes, but they're capable of infinite passage, whereas the other 2 will need to be replaced after X amount of passages. Examples of the heteroploid cell lines include the Hep2, the A549, or Viro cells. Table 29.3 lists the cell cultures commonly used in virology labs and their recovery rating based on the cell line used and the virus of interest, along with the cytopathic effect on the cells themselves. If you look at the herpes simplex virus, for example, you'll see that culture is recommended on the HDF, the human diploid fibroblasts, the Hep2, the human laryngeal cell lines, the RK rabbit kidney, and the A549 cell lines. And you'll see that it has good recovery to recommended recovery, which means that those are the recommended cell lines to be used. Whereas some of the other viruses listed here have variability on the cell lines. So different viruses require different cell lines for optimal recovery. So as mentioned before, the herpes simplex virus grows well on most cell lines, and the cytopathic effect that you notice is focal with plaques or clusters of infected cells. Cytomegalovirus has similar CPE to herpes virus, but it grows more slowly and only on the diploid fibroblasts. RSV, the respiratory syncytial virus, has syncytial formation on these cell lines, which means they appear as giant multinucleated cells. So these figures show comparisons of uninfected cell cultures and cell cultures showing CPE of viruses commonly isolated. So you'll see on figure A, the top left, that's showing an uninfected A549 cell line. And then on figure B, to the right top, you'll see that is the same A549 cell line, but it's infected with herpes simplex virus 2. So you'll note the CPE of large rounded cells, and that's also similarly described on table 29.3. Then on the bottom, you'll see uninfected Hep2 cells on the bottom left, figure J. And if you look to the bottom right, figure K, that is showing the Hep2 cell lines infected with RSV. So here you'll note the cinctia pattern, which is the observation of multinucleated cells that can result from the multiple cell fusions of the uninuclear cells. Adenovirus produces cell rounding on cell lines. These have a cluster of grapes appearance and have been described as diffuse or focal. Influenza virus typically does not produce cytopathic effects on cell lines. Infected cells instead express a viral hemagglutinin protein on the surface that binds to red blood cells. So instead of CPE, hemagglutination or hemaabsorption tests are used, in which clumping RBCs are detected with infected cells. This is an example of cytopathic effects on HeLa cells that are infected with adenovirus. So remember from table 29.3, adenovirus was described as large rounded cells in clusters. So you'll see there's clusters of larger round cells that appear on this cell culture. The centrifugation-enhanced shell vial technique can be used as a more rapid identification of viruses than traditional cell culture methods. Cell culture can take anywhere from 1 day to several weeks depending on the type of virus, whereas centrifugation-enhanced shell vial can take 24 to 48 hours. So with this method, the cells are grown on a round cover slip in a shell vial covered in culture media. The sample is then added and centrifugation is used to promote viral absorption to cells. This is then incubated for 24 to 48 hours and tested using immunofluorescence. Serologic assays can also be used, and these are typically performed on blood samples. So serology is used to detect circulating antibodies to viruses after exposure. So you're looking for immunoglobulin M or immunoglobulin G, IgM or IgG. Serology testing measures the host response rather than directly detecting the virus, so it's dependent on the ability of the host to respond and produce antibodies. Serology testing has both advantages and disadvantages in detecting viruses. The advantages include that testing can be quick and non-hazardous. There's the ability to detect non-culturable viruses, to determine the immune status of the patient, to be used in monitoring patients who are immunosuppressed, and serology testing is also good for use in epidemiologic or prevalence studies. Disadvantages include that serology testing does not work well in severely immunocompromised persons. Also, paired sera is typically required to demonstrate seroconversion or a four-fold rise in titer to establish diagnosis of recent infection. Therefore, serologic studies are usually retrospective. Other disadvantages include difficulty in interpretation of results due to the host status. So, patients who are immunocompromised, infants with maternal antibody, among other reasons, make it difficult to interpret the serology results. There's also the possibility of cross-reactivity between other antibodies. We're discussing the viruses in this chapter in groups based on their nucleic acid types. So whether they are double-stranded DNA, single-stranded DNA, double-stranded RNA, or single-stranded RNA. Of note, hepatitis are the only exception, and they will be discussed as one group because they do not all have the same type of nucleic acid. So first we'll be discussing the double-stranded DNA viruses. So the members discussed in this section include adenoviridae, herpes viridae, papillomaviridae, and poxviridae. So if you look at the lists below the group members, you'll see that a lot of these look familiar to you. For example, adenovirus, herpes simplex virus, varicella zoster. So these are the diseases we'll discuss in this section. So the first virus we discuss is adenovirus, a member of adenoviridae. So adenovirus was first isolated from the adenoid tissue and was thus named for the initial isolation location. Adenovirus is a naked icosahedral virus with double-stranded DNA. The common serotypes of adenovirus are serotypes 1 through 8, 11, 21, 35, 37, and 40. Clinical manifestations of adenovirus are dependent on the age and immune status of infected persons, with 50% of individuals being asymptomatic, 10% presenting with pneumonia, 5 to 15% with gastroenteritis, specifically in children, with this being caused by serotypes 40 and 41. In addition, keratoconjunctivitis, acute hemorrhagic cystitis, and pharyngeoconjunctival fever have been caused by adenovirus. The next group we'll discuss is herpes viridae. So this has 8 species of human herpes viruses that we're familiar with. So herpes viridae is an enveloped double-stranded DNA, and it includes herpes simplex virus 1, herpes simplex virus 2, varicella zoster virus, Epstein-Barr virus, human cytomegalovirus, human herpes virus 6, human herpes virus 7, and human herpes virus 8. All herpes viruses share the property of producing latency and possible lifelong persistence in their hosts. Herpes simplex virus infections can cause a wide spectrum of clinical manifestations, including oral herpes, genital herpes, neonatal herpes, herpes simplex virus encephalitis, and ocular herpes. Oral herpes were thought to have been caused by HSV1, but it is now known that a number of cases are caused by HSV2. Prodrome includes tingling and burning sensation, so these are early symptoms that indicate the onset of the infection. Once infection occurs, blistering ulcers and crusting lesions can be seen. With genital herpes, ulcers appear on the labia, vagina, cervix, shaft, and glands of the penis, urethra, and anal and perianal regions. Genital herpes infections are more often caused by HSV2 versus HSV1, whereas oral herpes are predominantly seen to be caused by HSV1. Transmission of HSV from infected mothers to neonates is less common than might be expected, but the risk of mother-to-infant transmission is 10 times higher when mothers have an unrecognized primary infection during labor and delivery. So neonatal herpes is acquired in utero or during birth or after birth. It occurs during vaginal delivery, and there's a 50% chance of transmission during active primary outbreaks. Disseminated neonatal disease has a 60% mortality rate in treated patients. Herpes simplex virus encephalitis is very rare, but it's a devastating disease with a mortality rate of 70%. The causative virus of encephalitis is herpes simplex virus 1 in adults and older children, and herpes simplex virus 2 in neonates. Ocular herpes occurs when the conjunctiva and cornea are infected with the virus, and this results in scarring during repeated reactivations. This is the leading cause of infectious blindness in developing countries. Diagnosing HSV infections is best made by antigen detection or viral isolation. Viral culture of lesion swabs or brain biopsy can be done and observe the cytopathic effects in 24 hours. Enzyme-linked virus-inducible system tests have also been developed, along with DFA for typing of isolates and molecular testing, such as polymerase chain reaction. This is an example of advanced cytopathic effects in an A549 cell line caused by herpes simplex virus. So remember, we looked at table 29.3 that describes the CPE of different viruses on cell lines. So remember, herpes simplex virus on the A549 cell line appears large, rounded, and when infected. Cytomegalovirus is a typical herpes virus, except that it replicates in human cells much more slowly compared with herpes simplex virus or varicella. CMV is spread through close contact. The virus has been found in saliva, tears, urine, stool, and breast milk. It can also be transmitted sexually via semen or vaginal secretions, via blood and blood products, and seroprevalence increases with age in all populations, with the highest prevalence of CMV infection among lower socioeconomic groups in crowded living spaces. Most CMV infections are asymptomatic in the immunocompetent host, but it can manifest as a self-limiting infectious mononucleosis-like illness with fever and hepatitis. Congenital infections are often symptomatic and can be serious. Clinical manifestations can develop if the mother acquires the primary infection during pregnancy. Congenital infection is unlikely to occur if the mother was seropositive at the time of conception. Symptomatic congenital infection is characterized by petechia, hepatosplenomegaly, microcephaly, and choriorhinitis. Other manifestations include reduced birth weight, central nervous system involvement, mental impairment, deafness, and even death. CMV infection can also become a significant life-threatening systemic disease involving almost any organ in immunocompromised patients, specifically transplant and HIV patients. The diagnosis of CMV infection is best confirmed by isolation of the virus from normally sterile body fluids, such as the buffy coat of blood or other internal fluids or tissues. It may take up to 3 weeks to see cytopathic effects in viral culture, whereas the shell vial method can reduce the time to as little as 1 day. There are also viral antigenemia tests available that are specific, rapid, and sensitive. So an example is the matrix phosphoprotein P65 test. So in this test, the nuclei of infected peripheral white blood cells are observed, and you can determine the viral load. As mentioned before, nucleic acid assays are also available using PCR. This is an example of a lung histopathology smear of an active cytomegalovirus lung infection in a patient with acquired immunodeficiency syndrome, or AIDS. The slide shows cytomegalic pneumocytes containing the characteristic intranuclear inclusions. This slide is of a pathology specimen, so would not be one routinely seen in the clinical lab. Epstein-Barr virus is the causative agent of infectious mononucleosis, also known as mono. Symptoms include sore throat, fever, lymphadenopathy, and swelling of the liver and the spleen, along with general malaise. Atypical lymphocytes are observed in the peripheral blood of patients with infectious mononucleosis. There has also been a link to cancers with Epstein-Barr virus infection, specifically Burkitt lymphoma, Hodgkin disease, and nasopharyngeal carcinoma, which have been associated with Epstein-Barr virus infection. Transmission of Epstein-Barr virus is usually via saliva, so it has also been termed the kissing disease. This is an example of an electron micrograph that shows Epstein-Barr virus. It's negatively stained, revealing the presence of numerous Epstein-Barr virus virions. Infection with Epstein-Barr virus occurs similar to other herpes viruses. There's a latency period with antibody production against the virus in adults. Infection occurs initially when the pharyngeal epithelium becomes exposed to the virus, and then it spreads to the circulating B lymphocytes. The B cells form memory cells at germinal centers, and this results in polyclonal antibody production. The virus then eventually infects the mucosal epithelium, and this is how it's transmitted in the saliva. Culture is not usually available for Epstein-Barr virus because it needs human B cells, so this is beyond the capabilities of most clinical virology laboratories. Complications of Epstein-Barr virus infections include splenic hemorrhage and rupture, hepatitis, thrombocytopenia purpura with hemolytic anemia, Ray's syndrome, which is a rare but serious condition that causes swelling in the liver and brain, encephalitis, along with other neurologic syndromes. Table 29.4 and Figure 29.9 show interpretations of Epstein-Barr virus serologic markers. So you'll notice the anti-VCA antibodies that are the antibodies against the viral capsid occur early in the infection and disappear in about 4 weeks. Anti-VCA IgM indicates current infection. IgG often appears in the acute stage and will persist for life at lower titers. Anti-EA IgG is the IgG antibody to early antigen, can appear in the acute phase, and its presence indicates current or recent infection. The antibody usually cannot be detected after 6 months. Anti-EAD, antibody to early antigen diffuse, appear in the acute phase, and their presence indicates current or recent infection. The antibodies usually cannot be detected after 6 months. Patients with NPC often have elevated levels of IgG and IgA anti-EAD antibodies. And of note, patients with NPC are those with nasopharyngeal carcinoma. Anti-EAR, antibody to early antigen restricted, appear in the acute phase and disappear soon after, but they can persist for up to 2 years and may be lifelong in some patients. Anti-EBNA, antibody to the EBV nuclear antigen, appear about 1 month after infection, with titers peaking in 6 to 12 months. This slide just summarizes the antibodies that we discussed on the previous slide for Epstein-Barr virus serology. So anti-VCA are the antibodies again for the viral capsid antigen. Anti-EA IgG are early antigen antibodies. Anti-EAD are early antigen diffuse antibodies. Anti-EAR are early antigen restricted antibodies. Anti-EBNA are Epstein-Barr nuclear antigen antibodies. And then PB is the pulmonal heterophile antibody. Varicella-Zoster virus is the causative agent of chickenpox and shingles. So varicella-zoster is transmitted via droplet inhalation or direct contact with infectious lesions. The primary infection that occurs is highly contagious. So varicella is accompanied by mild fever, body rash with red vesicular lesions, painful oral lesions, and sometimes this develops in adults. The lesions will dry and crust over in 1 to 2 weeks. Secondary reactivation of varicella zoster is known as zoster or shingles. So this usually occurs in adults when the virus remains latent after primary infection. The virus then travels down infected nerves and forms vesicular lesions in a band pattern. The most common presentation of shingles is a rash followed by vesicular lesions that may be painful and prolonged. Prolonged manifestations are referred to as post-herpetic neuralgia. When an adult is infected with shingles, they also must take caution because they can spread varicella zoster virus to children. An attenuated vaccine to prevent chickenpox was approved for use in the United States in 1995. Before routine use of the vaccine in children, an estimated 4 million to 5 million cases occurred annually. The vaccine is expected to give lifelong immunity. Typically, varicella zoster virus is diagnosed on the basis of characteristic clinical findings. In atypical cases such as immunocompromised patients, the diagnosis may be more difficult or questionable. So in these patients, detection would be warranted. So there's several methods available. Viral culture can be done with a turnaround time of 3 to 7 days. Patients would have samples collected from fresh lesions. Also, the use of fluorescent labeled monoclonal antibodies against varicella zoster virus confirms diagnosis. Over the last few years, molecular testing, such as amplified nucleic acid assays and polymerase chain reaction, have become the standard for diagnosis of disease. These assays are highly sensitive, rapid, and specific, and only require small specimen volumes for testing. This slide just shows an electron micrograph of varicella zoster virus to give you an idea of what the virus looks like under a microscope. Human herpes virus 6 is a common pathogen. About 95% of young adults are seropositive. Studies have also shown that the virus persists in salivary glands and has been isolated from stool specimens, but most evidence indicates that saliva is the most likely route of transmission. Usually infection occurs between 6 months and 2 years of age. For symptomatic infections, fever with maculopapular rash can be observed. In 30 to 40% of symptomatic cases, seizures can also occur. The diagnosis of human herpes virus 6 is usually made clinically. Isolation of the virus is the most sensitive with lymphocyte cell cultures, but this is not a typical practice for routine diagnosis. Serology may not be helpful unless paired sera are available. Human herpes virus 7 is the causative agent of roseola, which is clinically identical to human herpes virus 6. The infection is basically similar to human herpes virus 6, but it's antigenically distinct. So HHV7 is shed in saliva of about 75% of adults. Infection occurs between 2 to 6 years old, and the virus can be detected using PCR if needed. Human herpes virus 8 can be detected in all forms of Kaposi sarcoma. It's also known as Kaposi sarcoma-associated herpesvirus, or KSAH. This virus causes cancer in immunosuppressed persons, specifically transplant patients, HIV-positive patients, and patients with other immunosuppressive diseases. Human herpes virus 8 is likely transmitted via sexual contact. Kaposi sarcoma is a cancer that causes patches of abnormal tissues to grow under the skin. It can also occur in the lining of the mouth, nose, and throat, in lymph nodes, or on other organs. The patches usually appear black-brown. Currently, the virus cannot be recovered in cell cultures. Nucleic acid testing using PCR has been shown to be less sensitive than some immunologic assays. However, PCR has been used to detect the virus in various specimens, including tissue, blood, bone marrow, saliva, and semen. The DNA or antigens are rarely detected in immunocompetent individuals, even if they are seropositive. Now we'll move on to the next family of viruses. In the previous slides, we discussed all the viruses associated with the family Herpesviridae. The next slides will discuss Papillomaviridae. Human papillomavirus is the causative agent of a variety of warts, along with tumors in the respiratory, gastrointestinal, and genital tracts. There's more than 40 genital types, including low and high-risk genetic types for cervical cancers. There are more than 100 types of the human papillomaviruses, and as mentioned before, there are more than 40 types that are sexually transmitted and are known as genital types. The types are divided into cutaneous and mucosal. HPV 1, 2, 3, and 4, categorized under the cutaneous type, are thought to infect all children and young adults universally with no significant consequences. Different HPV types exhibit different tissue tropism based on the type of epithelial cells that the viruses infect. And this is why they're divided into the cutaneous and mucosal types. The genital HPVs are further categorized as low, intermediate, or high risk based on their association with genital tract cancers. All of this is summarized in Table 29.5 in your textbook. The genital type human papillomaviruses are transmitted via sexual contact. Detection of these viruses are done using cytology sections known as pap smears. The pap smears are examined for the stages of koilocytic atypia. So koilocytes are known as halo cells, and they're a type of epithelial cell that develops following a human papillomavirus infection. They're structurally different from other epithelial cells, as can be seen in the image to the bottom right. So their nuclei are irregular shaped in comparison to the rest of the cells. When examining and reporting out, the different choices of resulting include negative, atypical cells, low-grade lesions, high-grade lesions, and squamous carcinoma. A quadrivalent vaccine became available and approved by the FDA in 2006 for females aged 9 to 26. It protects against HPV type 6, 11, 16, and 18. HPV type 16 and 18s are those linked to the majority of cervical cancers and other HPV-associated cancers. There has been controversy about the use of these vaccines because it's recommended that they be administered at a very young age. Poxviridae is the next family of viruses we'll discuss. Pox viruses are among the largest of all viruses. They possess a characteristic brick shape and contain a double-stranded DNA genome. Members of Poxviridae include variola virus, vaccinia virus, the smallpox vaccine strain, monkeypox virus, cowpox virus, and other pox viruses. Variola virus is the causative agent of smallpox. This virus only infects humans and is transmitted via person-to-person contact. Variola virus is a highly infectious agent and can cause serious disease. The last reported case of smallpox in the United States was in 1949, and the last case worldwide was in Somalia in 1977. So by May of 1980, the World Health Organization had declared the world free of smallpox. Because now most humans are susceptible to variola virus, it remains a threat as a bioterrorist weapon. Although the virus has been eradicated, cultures are still maintained, one in the US at the CDC and another remains in Russia. This is a negatively stained transmission electron micrograph of the variola virus. Typically, smallpox is characterized as a synchronous progressive rash accompanied by fever. The incubation period is approximately 10 to 17 days. The patient then becomes febrile and oral lesions can appear. At this point, the patient is infectious. Within 24 to 48 hours, a faint macular rash develops on the body. The rash appears on all parts of the body, but lesions are present in greater concentration on the head and limbs, and this is described as centrifugal distribution. The macular rash progresses into papules and vesicles, and finally into pustules that resemble chickenpox lesions. The pustules are deeply embedded into tissues. As mentioned before, smallpox had been declared eradicated, so vaccination was stopped, and this is what makes the variola virus a possible bioterroristic agent. Monkeypox was first described in prions, hence the name. It can infect humans, but it's rare. It was introduced from rodents indigenous to Africa and occurs primarily in Central and Western Africa. When infections occur, they're accompanied by vesicular and pustular lesions, along with febrile illness. It presents similar to smallpox, but less severe. All the families and viruses discussed on previous slides were double-stranded DNA viruses. The next slides will be discussing our single-stranded DNA viruses. The group members include Parvoviridae. So this includes parvovirus 19 and human bocavirus. Infections with these viruses range from asymptomatic to potentially fatal. Parvoviridae are the smallest of the DNA viruses, and they are naked, single-stranded DNA viruses. Parvovirus B19 is the principal pathogen in the family. Infections range from symptomless to potentially fatal, with the most commonly recognized syndrome being erythema infectiosum, more commonly referred to as fifth disease. Symptoms of parvovirus infection include fever, headache, malaise, myalgia, respiratory and GI symptoms, and adults can also have symptoms of arthralgia, arthritis, or both. Patients with parvovirus infection have a slap cheek appearance and a rash that spreads to the trunk and limbs. It can last up to 2 weeks and can recur after heat and sunlight exposure. Hematologic manifestations of parvovirus include infection of red blood cells, which causes a decrease in the red cell production in the bone marrow. Complications can occur that include viremia, thrombocytopenia, granulocytopenia, pancytopenia, flu-like symptoms, and congestive heart failure. Patients with weakened immune systems are particularly at risk for serious complications. In utero infections can also occur, and this can cause hydrops fatalis, resulting in anemia. A novel parvovirus was described in 2005. It was named the human bocavirus, and it causes a variety of upper and lower respiratory tract illnesses. Symptoms include cough, rhinorrhea, fever, difficulty breathing, diarrhea, conjunctivitis, and rash. And infections typically occur during the winter months. Detection methods for parvovirus include molecular testing, real-time PCR, assays that are sensitive and specific for the virus. Now we'll move on to the double-stranded RNA viruses. So we've discussed previously all the DNA viruses, and we're moving on to RNA viruses. So the double-stranded RNA viruses include Reoviridae, which includes the groups rotavirus and Colorado tick fever virus. Rotaviruses are naked viruses. They belong to the genus Rotavirus. They're the most common cause of viral gastroenteritis in infants and children. Gastroenteritis is a major cause of infant death and failure to thrive. It's been estimated that rotavirus causes an estimated 611,000 deaths annually worldwide, with most outbreaks occurring in the winter months in the temperate zones and year-round in subtropical and tropical regions. Rotaviruses are spread by the fecal oral route and have an incubation period of 1 to 4 days. Symptoms generally occur suddenly and include vomiting, diarrhea, fever, and in many cases, abdominal pain and respiratory symptoms. The vomiting and diarrhea can cause rapid loss of fluids and dehydration. The rotavirus replicates in the epithelial cells in the tips of the microvilli of the small intestines, and this can destroy them, leading to malabsorption of nutrients. The virus is shed in large quantities in the stool, and it can also cause nosocomial outbreaks in the absence of good hygiene. Although the rotavirus is present in large numbers, it can be isolated only with special procedures. ELISA testing, enzyme-linked immunosorbent assays, and latex agglutination tests to detect viral antigens in fecal material have been used. With the introduction in 2006 of the rotavirus vaccine, a delay in the onset of rotavirus season from mid-November to late February was seen. RotaTeq is a series of 3 oral vaccines administered beginning at age 6 to 12 weeks. A second vaccine was approved in June 2008. During approximately the first year of an infant's life, rotavirus vaccine has prevented 85 to 98% of severe rotavirus illness episodes. The genus Coldavirus contains the Colorado tick fever virus that causes a dengue-like infection in the western US and Canada. Because Colorado tick fever is not reportable, actual numbers of cases are unknown, but it's thought to be one of the most common diseases transmitted by ticks in the US. The virus is transmitted by arthropods such as ticks and mosquitoes. The vector for infection is Derma center Andersonii. This tick has many hosts in nature, including deer, squirrels, and rabbits. Infected individuals develop fever, photophobia, myalgia, arthralgia, and chills. Similar to dengue fever, patients may experience biphasic fever with a rash, and children may have hemorrhagic fever. There are currently no commercially produced laboratory tests available for detecting Colorado tick virus, but there have been developments in recombinant immunoassays to detect IgG. Some nucleic acid-based assays using real-time PCR are also being utilized in research laboratories and may become available in the future. This concludes part 1 of the Virology Chapter 29. So the next section, part 2, will be covering single-stranded RNA viruses along with prions.